I'm Amber Tresca, and this is About IBD. I was diagnosed with ulcerative colitis as a teen and had J-pouch surgery 10 years later. Now, I help people with Crohn's disease and ulcerative colitis understand their disease and feel seen. On About IBD, you'll get real talk on symptoms, treatment, and life with IBD, straight from patients, caregivers, and experts. You'll learn, feel less alone, and even have a laugh along the way. Dr. Stephen Lupe is a clinical health psychologist and the director of behavioral medicine at the Department of Gastroenterology, Hepatology, and Nutrition in the Digestive Disease and Surgery Institute at Cleveland Clinic. His clinical and research interests include integrated care, inflammatory bowel disease, irritable bowel syndrome, brain-gut microbiome communication, acceptance and commitment therapy, and interdisciplinary treatment team approaches. Dr. Lupe helps patients navigate the intersection of chronic digestive disease, systemic stress, and mental well-being. Dr. Lupe, welcome to About IBD.
Thank you for having me.
It's really such a pleasure. And I just want to set up the episode. Today, we're discussing the experiences people with IBD have when they're seeking care in the emergency department, because this can create a situation called fragmented care, which is a term that I wasn't aware of until a few years ago. So I want to define it for our listeners. Fragmented care is when a patient sees different healthcare providers, but not all the information from those visits gets communicated between those providers. And every patient goes, oh, I've experienced that. I just maybe didn't know it had a name.
Yep.
So I want to start at the beginning, though, Dr. Lupe, because you have an interesting background. And so I want to ask you how you came to clinical psychology and your interest in IBD and digestive disease.
So it's kind of this long, wandering, meandering path.
Love it.
I had started, my undergraduate was in psychology, and I had started a master's in psychology. And my ex-wife and I had our daughter, and I needed to make money. So I became an EMT. And so there were not a whole lot of money in grad school, but became an EMT, progressed up and became a paramedic. And I was a 911 paramedic in South Florida for about 12 years.
Wow.
But doing that, one of the things I saw was we would go to these patients' homes and their pantries were full of Coca-Cola, Oreos. There was ashtray overflowing. There may be beer bottles. There was a stack of medical bills. And I kept thinking to myself, there is no way we are going to out-medicate that. And who is working with patients on those things? And so I decided to go back and become a clinical psychologist where I could do more of that work, and became a clinical health psychologist specifically. I thought it was going to be a pain psychologist working predominantly with patients who had pain conditions. And one of the things we saw at the University of Florida, where I was doing my internship and postdoc, was all of the patients with chronic abdominal pain, including all of the patients who had been diagnosed with IBD, were sent down to us. And so I saw a job posting, and I like to tease Dr. Ruggiero here a little bit, that it was for a pain psychologist. I applied for the pain psychology position, and about 3/4 of the way through the interview, it was like, no, you're going to build behavioral health inside of GI. And I said, okie dokie, let's do this. We started inside the inflammatory bowel disease clinic, and that was 2019. I started being in the hallway with my laptop right there. Physician goes in this room, dietitian goes in this room, I go in this room, and we all switch. And we come up with a whole comprehensive treatment plan for those patients. And it was very, very successful. So much so that we had to hire a second psychologist. And we're up to now 8 psychologists, and they're all still, and it just keeps growing and growing and growing. Just because patients get better if we take care of them as whole human beings, and we address all of the concerns that come with living with a chronic condition like inflammatory bowel disease.
Shocking, right? Shocking that is the case.
Well, and now we've even extended out to digital health. We have digital health partner that we're making sure, because one of the things that happened when I started doing this, I'd go around all these conferences talking to the physicians, and they go, we believe you. Yes, we need this. Now, how do I get a health psychologist? And like, if you're in rural Kansas, I don't know. And so we had to develop some digital interventions to be able to deliver some of those behavioral health interventions and some of the dietary interventions to patients who just could not get it.
Yeah, that makes sense. So it was Dr. Ruggiero's idea. Is that what you're saying?
Although I have to, he would laugh. He did look at me after I started. He goes, my first review, he goes, I didn't know what a health psychologist was when I hired you.
That's very funny. Oh, gosh. Well, his instincts were good. So we'll give him some credit on this, I think, so, yeah. And I saw many of as I was putting together the information for this episode, I saw some of the little shorts and clips and things that you've done from the different conferences that you've been to. So, it was really interesting to learn a little bit of how that's come about and how you think about this, because I think you're right. So anyway, one of the things that you've written about is the emergency department and understanding your background a little bit more. That makes total sense. And IBD patients end up in the emergency department from time to time. And so I'm wondering, what are you seeing or what are you hearing from your colleagues that are some of the more common reasons that people with IBD may end up in the emergency department?
That's a complicated question, right? Because there's multiple reasons. So there's usually a long treatment history for patients, and most of the patients I talk to do not want to go to the emergency room. Mm-hmm. And so they'll tell themselves, let me just wait another day. Let me see if I can this will get better. Let me see. Right. And it comes to a point where now it is a medical emergency, and there may even be something like a perforated colon or something like that. And at that point, it is a medical emergency. That person needs emergency care. Yeah. The other place that patients end up, though, in the emergency room, and this is more a flaw in our system, is that it is the receiving facility for anything that comes back. So if a patient calls their team, even, right, and we can't get them in the next week, and they're saying, it's like, well, go to the emergency room. Mm-hmm. And that's a really, really, really hard place because, like I said, most patients that we talk to do not want to go to the emergency room. Most emergency rooms are overwhelmed. They don't want to wait the 12 hours to get in. Mm-hmm. And then the staff doesn't know how to care for IBD effectively. And so it can become a very, very hard situation for patients to navigate.
Mm-hmm. Yeah, for sure. I actually interviewed a patient recently, and the pain from his Crohn's disease was so significant that his appendix burst. Mm-hmm. And he didn't, it really was all part of the same thing. Like, he didn't distinguish it. It was literally like someone who was with him noticed that his demeanor immediately changed. And they were like, I think it's time that we go to the emergency room. And that's what they ended up doing. But to think that that's the type of pain that people are dealing with at home simply to avoid the emergency room it's really striking.
It really is. And, that's one of the things I even work with patients on is how do we advocate for ourselves and how do we tell the teams that this is going on? But because it is hard when it gets to that point, right? Where there is now something really going on. There's a bowel obstruction. There's, and we're at the point where we need to figure out a way as a system with patients to be able to intervene earlier so that we can help them sooner. And I think the emergency rooms, to their credit, are trying to work on this. I've had conversations with emergency room physicians about what do we do when a patient with Crohn's disease comes in, and making sure that the staff is educated and stuff. And it's not like one of those things like, well, of course you have Crohn's disease. Because that's just dismissing patients. Mm-hmm. And most of the patients we work with, they know their bodies very, very well. Yeah. And they have a pain tolerance, and they're not there if they don't need to be. Mm-hmm.
Yeah, it's something that I say all the time. So as we know, as you were just describing, the emergency department isn't always the best place to deal with IBD. And that really is not a reflection or a broad statement about people that work in those spaces, because how could you possibly know everything about everything? IBD is difficult even for gastroenterologists that are trained in it.
Absolutely.
But as a consequence, sometimes people have negative experiences. That's why they may not want to go back to the emergency room. So what are some of the things that you're hearing that people are affected, that their mental health may take a hit when they end up going to the emergency room?
So we're starting to talk about this more too, this idea of like medical trauma. So there was some research that was put out by Tiffany Taff and a group of psychologists a couple years ago that they were looking at trauma symptoms for patients who had been diagnosed with IBD. And it was only 10% of the population they looked at that had no trauma symptoms whatsoever. So then 90% of the patients who have been diagnosed with IBD had some form of trauma. And that's not specifically medical trauma, but we know medical trauma is just as bad. And so you're looking at that going, so now this patient has this piece where they're trying to avoid care. Like I'm saying, they're trying to avoid going to these places. And that's a big problem. It increases anxiety around, symptoms. Is this going to be, do I have to go to the emergency room? And that in turn puts pressure on the brain, which then starts over detecting the body. And so there's all kinds of problems that come out of this.
Yeah. First of all, Dr. Taft, friend of the show, she was one of my first interviews. So thank you for bringing that up. I'll have to make sure that I link back to that episode and and link out to that research as well, because it was one of those things where those of us that live with an IBD were like, but having the numbers around it, I think, was really just so validating to so many of us.
Yeah. Dr. Taft's a good friend of mine. So.
Oh, amazing. I do enjoy her very much. So as you were also saying, one of the, I don't know, is it a blessing or a curse? People with IBD will power through just about anything. And we don't want people with IBD to do that, though. We want people to go and get care. So do you have any advice? If somebody realizes that they're at the point where they do need to go to the emergency room, all right, it's time. How can I prepare myself for that?
That's one of the things that we do a lot of work in is even getting the switch over to, right? Because when we go in, we have this total focus on the things I'm trying to avoid. I don't want the team to think I'm a drug seeker. I don't want the team to think I'm, whiny. I don't want the team to think I'm exaggerating. And it's like, time out. Let's work on that for a second. What are we trying to get out of this situation? Why would you have to go to the emergency room in the first place, right? Let's get the focus back on your care and your well-being and your health. And then it becomes, am I willing to even tolerate some of that to get the care I need, because I have some important things I need to do in my life. And I need to take care of my gut as part of that. And the disease I've been diagnosed with as part of that. I have to manage that. And this is part of that journey. And I would suggest, if somebody has gone through this and they've been through multiple bad experiences, they are noticing that anxiety when it does come time where they have to go to the emergency room, to really, those are also signs that may be a good idea to talk to someone like myself, or even a therapist within your local community. To try to work on what are some strategies I can do, because this is not an optional thing, right? This is part of care. I wish there was a better way to do it, but this is part of the care we got. And we need to help make sure, like you said, that we're trying to do that sooner and sooner and sooner and advocate for ourselves, because we want to avoid some of those downstream complications.
Yeah. And you make a valid point in something that I think about a lot, in that we can identify places where we want to change the healthcare system and where we want to improve things, but we are also functioning within the system that we currently have. And so we have to hold those two things and prepare ourselves for potential negative experiences until we get to the point where things improve.
Yep. Well, and, the medical system changes slowly. And that's a good thing and a bad thing. Right. I mean, it means that we're looking at the data when it comes to treatment and really making sure there's a strong data set or data there to justify changing treatments. And it's culture shift and everything else that we're working on currently with even what we're talking about, the emergency room. And how do we do culture shift around this, educate those providers better so that they know what to do for patients when they come in.
Exactly. Okay. Say somebody has decided they're going to the emergency room. What about while they're there or maybe directly after? Are there things that they can do to help themselves to sort of, I don't know, feel calmer or, even advocate for themselves?
Sure. Well, as far as feeling calmer, I always tell all the patients, right, when you're in the hospital, that's a great time to start doing some light practices for relaxation and stuff. You can download Calm, you can download Headspace for free and start, or not Headspace, Insight Timer for free and start doing something. Listen to your favorite music. The hospital is a great place for distraction. Normally, I don't preach distraction, but that is a wonderful place for distraction. And the other part of you're talking about the advocacy piece, we have to see when we're predicting outcomes beforehand, right? And be able to step into that spot and say, this is what I need. And that is a hard spot to be because we're all kind of trained from like the time we're little that like doctors know everything and they're kind of like the people that take care of us.
Yeah.
And so it is hard when we're not getting the answers we need or we don't feel the team to like is hearing us to kind of be like, I need you to hear me. This is what's happening in my body and this is not right. I always tell our patients, they are the experts of them. They live in their body 24/7 and know what is normal and what is not normal. And it is okay to tell the teams when something is not normal. There is an understanding here, and I think we need to do a better job at communicating this too, that sometimes the things we feel are not findable by our test as well. But it is always better to rule out those things and make sure, like you were saying with the person you were talking about, that there isn't something major going on, like your appendix is burst, or that there's a small bowel obstruction, or right, any number of things that can come up when you have been diagnosed with Crohn's disease or ulcerative colitis. And I think that that's important. When you see that and go, what are the things I can do here to help with that and help my body and take care of me in this moment? And sometimes that is advocating for myself.
For adults with Crohn's disease or ulcerative colitis symptoms, every choice matters. Tremfya offers self-injection or intravenous infusion from the start. Tremfya is administered as injections under the skin or infusions through a vein every 4 weeks, followed by injections under the skin every 4 or 8 weeks. If your doctor decides that you can self-inject Tremfya, proper training is required. Tremfya is a prescription medicine used to treat adults with moderately to severely active Crohn's disease and adults with moderately to severely active ulcerative colitis. Serious allergic reactions, increased risk of infections or lower ability to fight them, and liver problems may occur. Before treatment, get checked for infections and tuberculosis. Tell your doctor if you have an infection, flu-like symptoms, or need a vaccine. Explore what's possible. Ask your doctor about Tremfya today. Call 1-800-526-7736 to learn more or visit tremfyaradio.com.
Dr. Lupe, every IBD patient already knows this because we encounter healthcare providers who haven't been trained in IBD, and especially where resources are scarce, like you were saying, sometimes in rural places or places that are like really far from an IBD center like Cleveland. So I'm wondering, from the perspective of your colleagues, what are some of the things that they're doing or that they can do to help protect the mental health of IBD patients or help them through a stressful situation like an emergency room visit?
Well, I think first thing is getting the teams to acknowledge that psychological stress is part of this, right? In that it is normal for things to show up like tears and whatnot. It does not mean this person's depressed. It does not mean they have anxiety. It means they're going through a hard time. And we do a lot of education around that, trying to teach providers that, these are parts of this journey. And even if this person has been diagnosed with anxiety and stuff, that may not be what's going on now. And yes, even if it is part of what's going on now, it's probably not the whole the whole thing.
Yeah.
And so we really have to take into account the person that's sitting across from us, right? What does this person need? What are they telling me? And listening to it in a very, one of the other things we push for is trauma-informed care. That our patients who have been navigating a illness like IBD for any time, most of them, like we said before, have some trauma in the background, and we have to be sensitive to that we are going to step on that as a team, and we have to be prepared for it, and we have to know. And it's okay to even ask the person, are you doing okay? Right? Our providers to even be able to have those conversations. Also trying to ask the patient what has worked for them. The more control we give patients, the better they can navigate this from the provider side.
Yeah, that makes so much sense. So you are working on some of these things within the IBD Medical Home that you have at Cleveland Clinic. And so this is a model that it integrates behavioral health directly into gastroenterology. And I think a lot of IBD patients haven't ever heard of this. But now all of their ears are perking up. So I'm wondering if you can talk about the IBD Medical Home and tell us some of the basics and how it works.
Sure. It was a model that was actually developed in pediatrics. Imagine that peds was better at taking care of people than the adult world. And the medical home model is kind of this all services under one roof thing. And we all work as a team. And so as people would come in, they'd see the gastroenterologist, they'd see the psychologist, they'd see the dietitian. Eventually that will grow, and it is growing to include other disciplines like a radiologist even. We're very close with our rheumatology colleagues, stuff like that. So we can communicate directly with each other. And we all are there surrounding the patient. And we all are a resource for the patient. And you may not need one of those resources too, right? Let's say like a patient meets with me and we're like, actually, you're doing really, really great right now. Don't worry, I'm always here. I'm in the background. If something does change and we can work through it, we can talk about it. We can, there's a lot of different stages as someone navigates IBD. And so if you're not at a place for that, that's fine. We'll work on it when we get there. And we'll work on how do we optimize the body to make it so that it has the best chance of responding to the medications. But one of the advantages of this model, right, is there's so many touch points with patients that they have with us that we can all kind of pick up on stuff early as well. And this is even being extended out further, like I said, with the digital health stuff. So patients are logging their symptoms at home, even when they're not seeing us, and that team can communicate directly back with us. But it's not uncommon for me to hear from a patient. They come in and they go, you know what, Dr. Lupe, I'm really, really starting to experience some fatigue. I just can't get out of bed. I've got, I can't think. I've got brain fog, and I just feel like 1,000 pounds. And I may shoot a note over while I'm talking to that patient to the primary gastroenterologist going, hey, can we draw on iron? Can we get B12? Can we get vitamin D to make sure that it is not one of those things first? And then I will work with them on what do we do from a behavioral standpoint? What do we do from a dietary standpoint? Our dietitian colleagues, I always joke with them that they're my boss. They have to tell me what I'm doing before I can work with patients on how do we expand diet? How do we work with fears around food? How do we work through frank trauma around food sometimes? And we just have to treat this as a whole person thing. And like I said, eventually I think we're going to even move into the place where pelvic floor PT gets moved directly into the medical home. Our surgeons are within the medical home too. I'm a big fan of people meeting the surgeon early, even if they don't need them, so that you see that they're not a scary person hiding in the corner with a knife. I make that joke to my surgeon friends all the time. And so in this model keeps expanding. We've actually even expanded. We're getting ready to start our perioperative medical home so that patients who do have to have surgery, they'll be screened by psychology, a nurse practitioner, a dietitian prior to even surgery. We'll do an educational class, and then we can find the people that we need to work more one-on-one and get resources mobilized before the patient ever comes in. Make sure that psychiatry is involved so that we can get you medications to make this visit as easy as possible. The hospitalization as easy as possible. If someone needs pastoral care, let's get that moving. Let's get arts and medicine moving. We even have like therapy dogs, and it's like, yes, let's get the therapy dogs in there.
Gosh.
Everybody needs a golden retriever.
Yeah.
Right. And I think when we surround a patient, we look at it that way, and the team communicates with each other. That's another huge piece, right? I have no problem walking into any of my gastroenterologist colleagues' offices and going, hey, can I talk to you for a second? This is what I think's going on, and this is what I think needs to happen. What do you think? Right? We work like that. It's just much more effective, and patients feel much more heard. And we can work off each other's strengths and weaknesses as providers, right? Where if like maybe one of the gastroenterologists or a surgeon has to go in and give some hard news, I can go in then and help process this and figure out what's going on, which is another piece of education. I had to educate some of my friends who are surgeons. It doesn't work to just chase people into a corner and tell them you're going to die if you don't have surgery. We have to talk to the patient and figure out why they want to do this and make space. So, but that's another one of those things, like, you're playing off the strengths of all the team members and making sure this person is treated as a whole human being, as opposed to just a set of intestines that are walking around in the world.
Yeah. And, that's something that comes up often on this show. And when I attend medical conferences, it is something that whenever I am giving the patient voice, that is something that I remind folks of, is that asking us how many times we go to the bathroom every day isn't the beginning and the end of everything. So.
Yep. And we should be doing... we released a consensus statement a couple of years ago. I was one of the authors on the consensus statement through the Crohn's Colitis Foundation, talking about how we should spend more time asking patients about, psychological symptoms, psychological history, especially trauma. A lot of our exams are pretty invasive. And if you haven't asked about trauma history, there's a good chance you may step on it. And patient may have a very bad reaction, and that's going to lead them to try to avoid care, not want to come in, have more anxiety. Yeah. And so there's all of these things in there that benefit from working as a team.
I love it. Yeah. Great explanation. Thank you so much for taking me through that. And so,
of course,
IBD patients are, like I said, ears are perking up as they're listening to this, because it sounds like a dream come true. As we wait for more centers to put in this kind of 360 care, we have to work within the system that we have. Thankfully, we do have telehealth, I think, in a lot of places for people to access a dietitian or a therapist or a psychologist. So what are some of the other resources that you might suggest for people who, don't have this high touch one-on-one care necessarily with a mental health care provider?
Sure. Your team is a great resource. So make sure, you ask your team if you feel you have a need for things. We may have to ask for it in those places that it's not. One of the, piece of advice I always give to the teams, and this is throughout the country, is even if you don't have a psychologist, if there's a therapist locally or something and you can form a bidirectional relationship, I will refer to you. And let's talk a little bit about what this disease even is, so the therapist has some understanding of what's going on. That's there. Like I said, there's several digital health things that are coming out to make sure that we can connect patients with some behavioral health care in dietary care. My voice is on the one that we helped co-develop. And there's the Crohn's and Colitis Foundation has wonderful resources. They have vetted peer support groups, which most people don't know that exists, along with like all the different resources like the Can't Wait app and all that stuff. And those are so validating to a lot of patients. I think a lot of patients, I wish they'd go that way. A lot of our patients end up going through like Facebook and social media, and those are not bad resources, but they're not monitored. And a lot of times, you just get on these threads that are just the worst case scenario. And it can make anxiety much worse about the condition. And so I think that, trying to stick over to some of those more vetted resources can be helpful. I know the Crohn's Colitis Foundation even has like a peer mentor type program. I have some patients who are mentors in that, who, those are great things to have someone that you can call or text or message and go, hey, I'm experiencing this. Have you ever experienced anything like this? Or I'm frustrated. They just told me they're switching me to a biosimilar instead of my medication. And what do I do? Right. And I think that there's lots of resources there for what do we do, including, they even have some of the like appeals letters already drafted for some of the providers and stuff like that to help with that, which is so unfair. I wish we didn't live in a world where the patient has to show up with those resources for their gastroenterologist. But like you said, not all gastroenterologists are IBD experts, and they may be doing the best they can, but don't fully understand how to navigate this whole system and don't have a room full of resources like, medication navigators and stuff like that, like we do.
For sure. And social media is a wonderful tool for connecting with patients and for discovering community. But as I often remind people, sometimes what you are going to see on the internet is the worst case scenario. Like I know I live with a J pouch. I know a lot of patients who live with J pouches. It is not anything that they ever discuss because they're doing great and they're out living their life. So it's only the folks that have had a really difficult time of it that are actually in the support groups looking for help. So it gives a little bit of a skewed perspective of, post-surgical, for instance.
It does. And that's one of the reasons, like, I like those monitored, like more support groups, just because instead of it becoming one of those, like, this is just terrible, terrible, terrible. It's also like, then what can we do about this? Right? How do we live our lives even if this is going on? There's something that I end up, eventually saying to all of our patients as we work with them. It's like, do you have IBD or does IBD have you? And we've got to switch that equation over a lot of times because it's very easily being human beings in the way we learn, in the way our brain works for IBD to have us. And I don't want to leave. I just want safety. And, that can create some problems.
Yeah, for sure. So, Dr. Lupe, thank you so much for all of your time and taking me through everything. Is there anywhere you want to send people, anything you have online, any resources or anything else you want to talk about?
The resources we have. So like I said, I always tell people start with the Crohn's and Colitis Foundation, go there. It's amazing how many patients who have been diagnosed with IBD have not looked at any of the resources there. There's a couple digital health apps out there. The one that we partnered with is called Able, AYBLE, Health. I know that Oshi was doing some stuff there as well. There's several of them out there to try to connect people and improve access to make sure that there are some resources for patients as far as behavioral, psychological, brain-gut type connection and how that influences the course of, treatment and life when someone's been diagnosed with IBD. And, and I think, even the major health systems like the Cleveland Clinic, Mayo have great information for patients. And you can even pick up lots of information about diet and some of the lifestyle factors around living with IBD.
Perfect. I'll make sure that I put links to all those resources in the show notes. People shouldn't sleep on my show notes because they're usually pretty good, especially after talking with somebody that is as knowledgeable as you are, Dr. Lupe. Thank you so much for talking with me today. I really appreciate your time. And even more than that, I appreciate you dedicating your life's work to helping people with IBD. It really is so impactful.
Yeah, it's my honor. This is, I love my job. I love what I do. I love our patients. And so this is, thank you for having me.
Hey, super listener. Check the show notes to find links and information about the topics discussed in this episode. Plus, get a written transcript and much more on my website, aboutibd.com. If you enjoyed this episode, please consider sharing it with someone else or leaving a rating in your podcast app. Reviews and ratings help me grow this show and bring you more great content. Thanks for listening. And remember, until next time, I want you to know more about IBD. About IBD is a production of Mal and Tel Enterprises. It is edited, written, produced, and directed by me, Amber Tresca. Mix and sound design is by Mac Cooney. Theme music is from Cooney Studio.